Welcome to today's webinar, Opioids and Early Adversity, Connecting Childhood Trauma and Addiction, brought to you by NCSL. It is now my pleasure to turn the floor over to Kate Blackman. Kate, the floor is yours.
Thank you, and good afternoon, everyone. I'm Kate Blackman, and I'm a program manager here in the health program at NCSL. On behalf of the National Conference of State Legislatures, I would like to welcome all of you to today's webinar, Opioids and Early Adversity, Connecting Childhood Trauma and Addiction. Before I introduce today's fantastic panel of speakers, I want to thank the Centers for Disease Control and Prevention for their support. I also want to let you all know that today's webinar is being recorded and it will be available on the NCSL website next week as a video archive. We're so glad that you all have joined us today to learn about and discuss these two important topics, adverse childhood experiences and the opioid epidemic. I would like to give a special welcome to the Opioid Policy Fellows who have joined us today. The Fellows are a group of 24 legislators representing 22 states who applied and were selected to take a deep dive into opioid policy over the course of an 8-month program. This is the second of 2 webinars for the 2018 Opioid Policy Fellows program. You can learn more about this program on NCSL's website. During today's webinar, we will explore the intersection of adverse childhood experiences, or ACEs, and the opioid epidemic, and state strategies that have the potential to prevent and intervene in the cycle of ACEs and addiction. After a short background on NCSL, we will dive into these issues, first hearing from Dr. Melissa Merrick at the Centers for Disease Control and Prevention. Melissa Merrick is a behavioral scientist with the Surveillance Branch in the Division of Violence Prevention at the National Center for Injury Prevention and Control. Her major research interests focus on the prevention of child maltreatment. Dr. Merrick serves as a lead scientist for the Adverse Childhood Experiences Study in the Division of Violence Prevention and as a subject matter expert for child maltreatment. Following her presentation, we will have the opportunity to explore 2 states' approaches to addressing ACEs and addiction with Representative Cameron Sexton and Representative Ann Pugh. Representative Cameron Sexton is in his 3rd term of the Tennessee General Assembly. Representative Sexton serves on multiple committees and is the chair of the House Health Committee. He was also recently appointed as a member of the Opioid Task Force. Outside of the legislature, he works in business development at the Cumberland County Bank. Representative Ann Pugh has served in the Vermont House of Representatives since 1993. Representative Pugh serves as chair of the House Committee on Human Services and the Joint Legislative Child Protection Oversight Committee. Outside of the legislature, she is a full-time faculty member in the Department of Social Work at the University of Vermont. Representative Pugh and Representative Sexton are both opioid policy fellows this year, and we're very happy to have them with us. There will also be time for Q&A at the end of the presentations, and participants can ask questions at any time during the webinar. You can enter your questions into the Q&A box on the bottom left-hand side of the screen, where Representative Mizuno from Hawaii has already initiated the conversation. If you would like, you can specify which speaker you're addressing your question to, and I will read the question and ask speakers to address them. We also hope that you can share some of the innovations happening in your own states around these issues. We will seek to answer all questions during the webinar, but please note that we will prioritize those from the Opioid Policy Fellows and other NCSL members. The slides are available for you to download in the media library, which you can access near the top right part of your screen above where you see the slides now. Click on the icon that looks like a piece of paper with a play symbol or a little triangle in the middle of it. First, I would like to provide just a bit of background about NCSL for those who may not be familiar. NCSL is the national bipartisan membership organization of state legislatures. Our members are all 7,383 state legislators and more than 30,000 legislative staff in all 50 states and the territories. NCSL seeks to support state legislatures and promote innovation and communication between state policymakers. We provide research, education, and technical assistance. Our state policy research staff is based here in Denver, Colorado, where it's currently snowing. We cover every policy issue that legislatures touch, including education, health and human services, transportation, energy and environment, criminal justice, and more. We also have an office in Washington, D.C. that works on federal policy and provides a cohesive voice for states at the federal level. I would also like to remind participants that NCSL does not advocate for specific policies, nor do we take positions on state issues. This webinar is a platform for information exchange. And so without further ado, I will turn it over to our first speaker, Dr. Melissa Merrick. Melissa?
Great. Thank you, Kate, and thank you, NCSL, for inviting me today. I'm delighted to be here to share a little bit about what we know related to childhood trauma and addiction. Obviously, we know that they're connected in multiple ways, and I'm thrilled to be joined with Representatives Sexton and Hugh, and really looking forward to hearing and learning from them and their expertise in this area as well. But obviously, childhood trauma and addiction are connected in multiple ways. On the one hand, we know that early adversity, like ACEs, which we're going to talk a little bit about, can really set people on a trajectory towards substance use, including opioid use. And then, of course, we know that among adults that are using substances or are addicted to opioids, we know that there's often kids in these homes and even babies born addicted to these substances themselves. So we really think about this as a two-generation issue, and therefore we're interested at CDC in real dual-generation approaches to prevention, including these upstream strategies at primary prevention of early adversity, so stopping early adversity before it starts in the first place. And when I'm talking about ACEs, I'm mostly talking about these on this slide here from the original Kaiser CDC ACE study, which looked at, among adults, about 17,000 insured adults in San Diego, part of an HMO, Kaiser Permanente. They were asked to retrospectively report on their experiences of abuse, neglect, and various forms of household challenges that they may have experienced under the age of 18. So a couple limitations. Obviously, this is not the entire universe of early adversity or childhood trauma that we know our kids in this country and around the world are experiencing. There you can see on the right some additional types of adversity that we study in the Division of Violence Prevention. But nevertheless, the ACE score really gives you an idea of how many of these different kinds of early adversity kids experienced or adults experienced when they were children. So obviously, we're also bound by retrospective recall biases and other things like that. But regardless of the data source, ACEs have a very robust literature. There have been over 40 health outcomes associated with these experiences of early adversity, and we find two main findings: that ACEs are common. So across data source, across population, we know at least two-thirds or approximately two-thirds of adults have at least an ACE score of 1. And we know that approximately 20% of adults have 3 or more ACEs. And, the second thing that we know is that it's not just that ACEs are common, it's that across over 40 health outcomes, we see these robust patterns where ACEs are connected with injury outcomes, mental health, maternal health and reproductive health, infectious disease, chronic disease, health risk behaviors, including substance use and misuse, and then various forms of life opportunities. So as your ACEs increase, so too does your risk for a whole host of negative health outcomes. So in this way, we see preventing early adversity as being very strategic in terms of achieving multiple public health goals, including, reducing opioid addiction. And here you can see some kind of specific slides that relate to the outcomes that we're interested in discussing today. We've, as you all know well on this webinar, that in recent years we have witnessed dramatic increases in 2 major causes of death: opioid overdose and suicide. And so you can see here these patterns where, it's as your ACE score increases on the x-axis, so too does your risk for IV drug use here on the left, or adult suicide attempts. Men with 6 or more ACEs are 46 times more likely to have injected drugs than men with no history of ACEs. And here you can see this paper is currently under review at a journal, but, various states, there are over 40 states and the District of Columbia that collect ACE information on their behavioral risk factor surveillance system, or BRFSS, a large random digit dial health survey, which is great when you also, collect ACE information on there. You can link it with various health outcomes. So here you can see, this is Montana BRFSS data from 2011, but you can see on the left This is the outcome is using at a higher frequency or dosage than directed by a doctor, using prescription pain medication, and on the right, using without a prescription at all or without something that was prescribed to you. So you can see the same very robust graded dose response impact. Again, as your early adversity score increases, so too does your risk of misusing prescription pain medication. And the wide-ranging health and social consequences of ACEs really underscore the importance of preventing them before they happen in the first place. And here you can see this slide represents findings from a study done in the UK, so not in the United States. But the general message is still the same, that if we prevent early adversity before it occurs, we can help reduce the levels of a range of health conditions, from smoking to poor diet to heroin use. And how we're doing that more and more at CDC and more in the Division of Violence Prevention is really to work at the bottom layer of this health impact pyramid. So although in this space of childhood trauma, I should share that my background is my PhD is in child psychology. So I'm a clinical psychologist by training and have been in public health maybe the last 9 years or so. So my work traditionally had been focused at the top of this pyramid. Also very important, of course, to have trauma-informed services, trauma-informed clinical interventions. But really, if we want to really prioritize population-level impacts, we need to be focused more at the bottom of this pyramid that really looks at the socioeconomic or the conditions or the context of these experiences. And that really is where we get into a lot of our policy levers. And so we have recently developed a whole suite of these technical packages, kind of a weird name for a good resource. It's basically we took the best available evidence for all of our topics in the Division of Violence Prevention. So there's a technical package on the best available evidence for preventing suicide, for preventing youth violence, sexual violence, child abuse and neglect. That's where this ACEs work lives, of course. And intimate partner violence. There's a fifth one as well. And we're basically trying to now elevate these policy level strategies to really prevent multiple health outcomes. And here you can see the ones that are really specific to preventing early adversity, or ACEs. So you can see 5 general buckets, if you will. So strengthening economic supports for families. That one we see as more about the conditions and more about the policy level strategies that really have, again, the potential to make the most population level impact. And then you can see we go to more kind of individual buckets as we go along here. So changing social norms to support parents and positive parenting, providing quality care and education early in life, enhancing parenting skills to promote healthy child development, and then, of course, intervening to lessen harms and prevent future risks. So I'm just going to give you a little flavor of what's included in the technical package as it relates to policy level strategies or options. So here, our first bucket, like I said, is about strengthening economic supports to families. So this strengthening household financial security really is associated with preventing early adversity, because we know that one of the major risk factors for child abuse and neglect and other kinds of early adversities for kids is parental stress, parental depression. Often, providing more financial security through these mechanisms has been associated with evidence to decrease child abuse and neglect and other forms of early adversity. So although there's lots of things listed here like child support pass-throughs, of course we can, states can elect to take less, to allow more of the child support to pass through versus reimbursing themselves for temporary assistance for needy family benefits, tax credits like the earned income tax credit. But then when I want to just talk about some policy options is in terms of the subsidized child care. We know that, if we can better meet demand and not have wait lists, if we can increase coverage of early Head Start, reduce co-pays for families, all of these have been associated with evidence of reducing early adversity in these families. On the next slide, another way of strengthening economic supports to families is through family-friendly work policies. I will say that recently we have been increasingly interested in building our business case for prevention. So really talking with business leaders about, what they're doing to really maximize return on investment and how that that's supporting families through livable wage, paid leave, consistent, flexible schedules, helps them also increase productivity. So they're getting the dual benefit, if you will. And so we can see in some states that have increased minimum wage by just $1 has been associated with 10% declines or reductions in child neglect. So these are things that do have evidence behind them, and is something that we've included a lot of the resources and evidence, the literature that supports these policies in our technical package, which you're able to, of course, download for free on our website. This next bucket, providing quality care and education early in life. We've talked a little bit about child care, but, even just increasing slots for state pre-K with parent involvement has been a key policy strategy in multiple states, increasing slots for Head Start in general, of course. And then always quality, it's not just the availability, but it's also the quality of state pre-K, which has been seen to reduce child maltreatment in particular. But here, intervening to lessen harms and prevent future risks. That was kind of the fourth bucket. But there's, real policy strategies here, too, in terms of enhanced primary care. So, for example, the SEEK model is where you screen for intimate partner violence, but in primary care settings. And then, if someone endorses intimate partner violence and other kinds of stressors, adversities, then you would put prevention services in place for those families. And there's so far been 2 randomized controlled trials that showed that routinely screening mothers of young children for depression, substance abuse, and exposure to intimate partner violence, and then providing the services as needed, significantly reduced mothers' psychological aggression and physical assaults of their child, as well as reduced substantiated reports of child maltreatment. So again, looking at this dual generation approach to prevention, we have to also kind of understand parents' own histories and experiences of violence and other kinds of adversity, because then, of course, when children grow up in that house, that makes the children more at risk to having their own early adversity. So really, again, this dual generation approach to prevention. And then, of course, there's social norms, support parents and positive parenting, legislative approaches that have some evidence that, is building in the U.S. And really, we're learning more and more that we can't do this work in public health alone. Although we believe at CDC, as the leading public health agency for our country, we need to be leaders in this space, but certainly we need to work across sector, many of the sectors that are listed here and more in creative ways to really understand how trauma, how childhood adversity really sets our kids on this trajectory toward later health impacts and problems like, for example, addiction and opioid use, but also how we can together really build a new narrative that talks about this dual generation approach to prevention. So I just wanted to quickly also share a couple things that are happening in that space in kind of different creative ways. So this, you see this snapshot of the Martinsburg Initiative. It's really an innovative partnership that is developed between Martinsburg Police Department and Berkeley County Schools. So it's really about understanding, how early adversity, again, sets our kids on this trajectory towards substance use, and how those that maybe are touching law enforcement and police departments that have opioid addiction or substance use problems, how we have to be trauma informed in understanding how they got there in the first place. And then, of course, if there's kids living in the home. So, the chief of police there, Chief Richards, has really, been kind of creative in his public health approach to law enforcement, if you will. And he says that, he's quoted as saying, "We will never reduce the supply of drugs unless we reduce the demand for drugs. And the only long-term cure for the opioid epidemic is to stop people from starting drug use in the first place. And that requires a prevention strategy that works." So hearing law enforcement, come to speak about primary prevention and prevention at all is really something that's, evolved over time. We see it, often as more of a punitive or, a response versus a preventative, sector. But as we develop these strong partnerships, I think even law enforcement is becoming more and more trauma-informed and trauma-savvy. And then the other example is, let's see if it pops up here. Okay, there you go. You see a snapshot of our recent work with the Appalachian Regional Commission. They are really an economic development agency of the federal government and 13 state governments, focusing on 420 counties across Appalachia. And really, they had some work going on with the National Center for Injury Prevention and Control, where the Division of Violence Prevention lives at CDC, but also where all the opioid work is happening at CDC. And they had, a partnership really solely about opioid use. And we were able to, again, help them connect childhood trauma with opioids, and really had a wonderful think tank session where, they had people from their area really talk about the connections that they see. So we're just starting to partner with them, but again, trying to, move to this dual generation approach and helping people understand the connections between preventing early adversity and achieving multiple public health goals, including reducing opioid use and misuse. So I leave you with this quote by Jack Shonkoff: one of the most powerful ways to change the world is to make it better for kids. And I truly believe that one of the best ways or most powerful ways we can make it better for kids is by preventing early adversity in the first place. So with that, I will turn it over to my next speaker. Thank you very much for your attention.
And we're excited to build on that foundation with Representative Sexton and Representative Pugh talking about the work in their states. So now I will turn it over to Representative Sexton from Tennessee.
Thank you very much. On this, we're going to talk a little bit about what Tennessee has seen. And a UT health care professional, Dr. Daniel Shumrock, has said, and I think it's been quoted, that it's not the drugs, it's about childhood, adverse childhood experiences. And we know that 75% of substance abuse disorders have some type of ACE associated with them. And here in Tennessee, this is just a graph to kind of show that whether you're living in poverty or not in poverty, it affects both equally. This type of problem does not associate with economic class or development. And in Tennessee, we've seen in the last few years an increase in people seeking opioid treatment, more so than other treatments, and I think that goes with the graph that everybody has seen. But we've had a significant increase in those seeking treatment for opioid use disorders compared to just overall. 7,000 of those last year that we're looking at. Also in Tennessee, 52% of the state's population has at least one ACE, while 21% have 3 or more. The percentages here are broken down by kind of how they're seen. Obviously, parents divorcing and separation is the biggest. But if you're looking at substance abuse disorder with a household member and mentally ill household member, would make up a significant portion of that, as well as you also know that you're more than likely to abuse the more ACEs that you have as well. That goes along with that. In 2015, Tennessee did a study looking at building strong brains, and through that study, we opened up a grant process in Tennessee. And last year, there was 8 grants that were done. Sort of the difference, it's kind of from all over the board. With higher education, the Tennessee Board of Regents are working with our community colleges and providing with teachers more classroom work on how to determine about ACEs. One of the other grants were to do 3 after-school sites for at-risk youth in the rural areas where we've had a huge problems with opioids misuse. Home visiting and building on parents' strengths and using evidence-based intervention to mitigate toxic stresses was another area of a grant. And one of the other ones, too, is to, in the Upper Cumberland area, which promotes a lot of the rural counties in Tennessee, to allow them to do 30-second PSAs through the PBS stations talking about ACEs and the effects and those issues surfacing. So we set up a grant process. It's still kind of early to determine the successfulness of everything, but those are sort of the things that we have been going through a little bit. We also started collaborations with a parents program through Frontier Health, which support high-risk mothers and with NAS infants in collaboration. Also looking at adding expertise into the OB/GYN offices, just because we have plateaued on NAS births in the state of Tennessee over the last 3 years. We've been kind of holding steady and haven't increased or decreased any, and trying to do more community outreach in our state. One model here is through Vanderbilt University, and I think the point here that we're trying to make is a lot of times it doesn't require legislation. It just requires people to think about things a little differently. And Vanderbilt University Medical Center has worked with a children's hospital to kind of change how they care for NAS babies and the mothers who are there. And what they've seen in a short period of time with their program or their Hope Care model is to basically the median length of the stay is 5 days, which is a lot shorter than the national average. And also only 8 of the 67 babies needed 1 or more doses of morphine to manage the symptoms. And quite frankly, all they really did is instead of separating the mother and child at birth, they worked to try to keep them intact and together so that they could work off one another. And that has led to great success so far in their program, which will hopefully lead to other models and working in other hospitals throughout the state. One thing I will say, too, is secondary education, higher education, we're starting to look at that for ACEs as well. When you look at our colleges, community colleges or four-year colleges, they all have increased the number of counselors and psychologists on campuses to handle the ACEs, meaning the individuals who are having depression or anxiety, substance abuse problems, even suicidal thoughts. They have really increased the amount of people who can help those individuals on campus and really have started doing a better job of working to help those individuals. The problem we see in Tennessee is through K through 12 education, our ratios for guidance counselors are still way too high, and we don't have any school psychologists. And so as you look at everything that's been done in the nation and in the schools, and if you want to look at the school shootings, almost always those are internal threats. They haven't been external threats. And so what we're trying to look at, trying to figure out how to do is make the guidance counselors go back and be guidance counselors again, also add a higher level of expertise with psychologists, and really try to get into the school systems where these students are for the majority of their day. And we know through very short questioning on how many ACEs they have and the likelihood and risk associated with them, but really doing a better job in our schools of trying to help those individuals early in their life and where they're not having to go through as much as they have. In Tennessee, between the ages of 10 and 24, we average about a suicide every 4 days in that age bracket, unfortunately. You know, the other thing that we're looking at, too, is Knoxville has started a pilot program in their school systems. It's called Community Schools, where they partner with private businesses, and they do school after hours up till 8 or 9 o'clock at night and change sort of how that school functions and makes it more of a building character, building hope in the hours from 4 to 8 or 9 in the evening, because a lot of parents work second shifts. It's a way to get the community involved, and also it provides them with a meal at the end of the night with their family at school, which would give them another meal. And what you've seen in Knoxville in those inner city schools and those schools that it's in, it went from being in 2 schools in Knoxville to now over 18 schools. And they're seeing huge results in making that change. The last thing I'll say, too, is we're working with physicians and healthcare practitioners in doing a better job of determining risk factors with their patients when everybody goes to the physician, they ask you to check yes or no on 100 different questions. And in there, you could do risk assessments on individuals and really dive in to see if you're going to prescribe them a pain medication or something else, the likelihood of misuse based off how they answer those questions, because it does correlate over into that. So in the end, you know, as we say at the bottom, they don't predict just substance abuse disorder, the ACEs. It does affect chronic diseases linked to substance abuse. And I think no longer can we keep this silent, and we really have to go back and re-look at how we do everything, especially in those early years, whether it's pre-K or K through 12. And with that, I'm going to turn it over to the next presenter.
Thank you, Representative Sexton. Now we will hear from Representative Pugh from Vermont. Representative, I'll turn it to you.
Thank you very much. I'm Representative Ann Pugh, and I'm going to start with sort of our public health approach and frame for opiates, and then move to the intersection in some of our programs and policy responses between addressing early adversity and addiction. What you will see from this picture right here is that we really are taking a very integrated public health approach that intersects with the philosophy of building flourishing communities and, on some level, removing silos. The goal is in a sense, to prevent and eliminate the problems caused by alcohol and opiates and other abuses. And I might say, especially based on what we just heard from Dr. Merrick and Representative Sexton, we can look at this same model in terms of how we address ACEs. In terms of our picture in terms of alcohol, opiates, and other substance use disorders, this reflects a comprehensive set of strategies and tactics that address the full spectrum of services, from harm reduction and promoting a healthy lifestyle, from identifying and acting on early signs of substance abuse, for instance, using some evidence-based programs such as SBIRT, to treatment, which is our hub and spokes, or the Care Alliance, which I'll talk about in the next slide, to then moving to ensuring an environment that supports Vermonters with sustained wellness, whether it is focused on the opiates and substance use disorders in terms of recovery centers, or other pieces that we can put into place to ensure a healthy environment. It focuses on all aspects of response, from clinical or direct service, from planning, a community-based, intersecting with community, policy, and legislative, and at all levels in terms of the state, the local, the family, the individual, and the school. Our hub and spoke model, or our care collaborative, is primarily is an outpatient model where the established goal is to have a physician-led medical home. It intersects with our Department of Health Access, which is on some level our Medicaid payment agency, our Blueprint for Health, which is an innovative model of primary care intersecting with social service or counselors in terms of improving outcomes for people in their medical home, and with the Department of Health and their Division of Alcohol and Drug Abuse. There we have a hub, our methadone clinics, where you need to, where it's the only place at this point where you can get methadone per se, and for people who are at the beginning, and these are community-based, and whereas some either transition to their primary care physician or to a physician in the community, or some others can start there at the beginning. All of our treatment in terms of the hub and spoke requires counseling and connection between anything that the patient is going to need. Some of the characteristics of it is that really the movement is to have an established physician-led medical home, to only have one provider, to only have one pharmacy, and this is to make the connection to the community health team. The people in that community health team, depending upon the situation of the individual and the family and their family, they may be connected with a nutritionist, with someone who can help with connection for basic needs, be it housing or food or job training, those kinds of things. So that's the access to the hub and spoke nurses and clinicians. And there is a distinct and very direct link between the hub, which is your methadone clinic, and the primary care spoke providers. We have methadone clinics in 8 areas of the state, and our waiting list now is we're almost at the ability to have treatment on demand in terms of access to methadone. Almost, not quite, but we're getting there. Oops, how do I, oops. Kate?
Yes, ma'am.
Oh, wait a minute, I might get it. Oops, sorry. I just, in terms of the evaluation, we had a small study of it, and you can see that the evaluation of combining regular and very clear and directed, first a clinic with the wraparound supports, and then movement to your primary care physician. The people who were in treatment, you can see that there was really, the results were really very, very excellent in the sense of they really showed that that treatment works, that treatment connected with other support, with medication connected to other supports is important. So the findings are encouraging. They provide really insight into the successes of the hub and spoke system, but also insight into how dramatically someone's life can be changed with the use of medication-assisted treatment. As you can see, those who were not in treatment continued to sort of lead very precarious lives. That said, what we want to do is try to build resilience. And some of what Vermont has done, I wanted to talk a little bit about in the next few slides. One that really connects, I want to say, in attempts to build resilience or prevent future problems is our CHARM program, Children and Recovering Moms Collaborative. It is a nationally recognized program that really has that is a collaborative comprehensive care coordination for pregnant women with opioid use disorders and provides consultation for child welfare, medical, and addiction professionals. There are 10 organizations that collectively provide this. They are empaneled as a multidisciplinary team based on state law. They meet monthly to discuss the needs of upwards of 100 clients during any one monthly meeting. The benefits that have been seen include healthier pregnancies, healthier children, and a greater chance for the children and for the children to remain at home and the families to remain together, or for the families to be reunited. This is actually something that started without legislation, but rather through grants and through the identification by a OBGYN who was seeing an increase in mothers who were addicted, and wanting to figure out how we could put a stop to that and how we could address that. Another way that we are doing this is the Agency of Human Services, which in Vermont includes corrections, but has health care, mental health, child protective services, child care. There is a Vermont trauma work group, which includes upwards of, it's a collaborative, an informal collaborative of over 70 individuals, both from within state government and our collaborating nonprofit agencies, and they get together on a regular basis to identify and to form a common philosophy and to focus on the importance of reframing and redesigning the way we do our work and provide our programs. All of this, in a lot of ways, is built on the concept of resilience and trying to prevent adverse childhood events, prevent those things, and then to address them. Another program, another response, again, that was able to be done without legislative intervention at this point was Project Vision, which is in the southern part of Vermont. Community partners came together to address substance use, reduce crime, and build stronger neighborhoods, all of which are important for building resilience and strengthening protective factors so that we can prevent future problems. What it did is it broke down silos, and in fact, it was centered in the police, and the police department were partnering with social service agencies. And it has shown in this community a growing sense of community togetherness, a reduction in the increase in opiate addiction, and a reducing of silos and increasing collaboration in terms of that. I want to go to the next slide before I go to the legislative, how we responded legislatively. Dulce is a really exciting community response. It's a pilot project. We are one of 7 sites in three states where, excuse me, the cat just, I apologize, I'm at home. The cat just took my papers away. Dulce is a national demonstration project sponsored by the Center for the Study of Social Policy, and its intervention incorporates the Strengthening Families Protective Approach. It includes these five core elements. Universal access. What it is it embeds a family worker, a social worker who is an employee of a regional parent-child center. It embeds that social worker in a primary care office, and who can connect families to resources based on the parents' needs and priorities. Where this differs from some other models that talk about which we also have in Vermont, which has the primary care or the hospital hiring the family worker or the social worker and embedding them in the primary care offices. The difference here is that the family worker, the social worker, is actually an employee of the parent-child center, so in fact can do the referrals and the touch to the agency in which they work. So the core elements of DULCE, and DULCE, as this says, stands for Developmental Understanding and Legal Collaboration for Everyone. And the first element is universal access. So all newborns and infants within this geographic area are offered DULCE services. The family specialist or social worker from the parent-child center is a part of the primary care team. The medical legal partnership, a legal aid lawyer advises and supports the family specialist or the social worker as they are assisting families, whether it is in terms of obtaining benefits or if they're having some challenges with housing or if they're having some challenges with the law. Clearly, parents are viewed as partners in this, and so a parent is actually part of the conversations and the quality improvement and data team. And finally, DULCE is embedded in the rest of the child and family services within that geographic area. And a randomized trial evaluation has revealed that this has seen improvements in health outcomes and a reduction in people not having their concrete supports met. So to put it more positively, is accelerated their access to concrete supports. So it really, we think, offers a promising method for delivering services that seems to improve preventative service delivery, therefore, would improve outcomes. Now, legislatively, we've been very interested in this. To begin with, in terms of focusing primarily on opiates, but you can't focus on opiates without thinking about the family and the children. Our governor, Phil Scott, put in his cabinet, at the cabinet level, we have a drug policy individual who is responsible for the Vermont Opioid Coordination Council. And having someone at that level focusing on prevention, which is where ACEs and adverse family experiences come in, and includes then education and the state police and the Agency of Human Services, as well as workforce. Most recently, in last year, the legislature passed Act 43 of 2017, and what it did was it put a new chapter in our human services statute where we outlined the principles of what was important for promotion of child and family resilience, and principles for Vermont's trauma-informed system of care, and we then also asked the Agency of Human Services, along with the Agency of Education, to do an inventory of what was happening right now in Vermont. And the outcome of that was a 43-page document talking about 282 programs that support 3 or more of the protective factors that need to be developed, and when we look at these areas. In development, when I say in progress, that's why they have an H and an S. In process right now, is an update to our workforce development and really infusing the two-generation approach there, which would be connected to families, employees having multiple needs and helping employers understand that someone who misses work or comes in late, maybe coming in late because they're going to treatment, or someone who misses work because their child is sick, and how to work on that. And that was infused in the in this bill. And S-261, an act relating to mitigating trauma and toxic stress, is the second half of what we started last year, and it is outlining the elements and identifying the fact that there are a lot of things going on, but what people don't know is how to coordinate and how to evaluate. So it identifies, it creates a position of a trauma coordinator within the Agency of Human Services, and asks for, we began to do an inventory, so we have an inventory of what there is, and now we need to more clearly identify the gaps and where we can put our needs in terms of that. So with that, those are a couple of the pieces. Although I do want to, I have to say something, a very small piece that we did in Vermont in terms of strengthening economic supports, which was which was a small step in terms of what I would call the child care benefits cliff. As we all know, as families earn more money, they lose access to perhaps some child care financial assistance. And what we passed last year was a bill that would enable parents to maintain, employed parents to maintain their level of child care assistance if they put the difference between their existing salary and their raise in either a child savings account or an IRA. So in other words, to build assets and to plan for the future. So with that, I will stop. Thank you very much. It's been an honor. Loved hearing from Dr. Merrick and Representative Sexton. It was really interesting hearing what's going on in Texas. Oh, in Tennessee, sorry.
Thank you, Representative Pugh, and thank you to everyone for your talks and for the conversation that has been taking place in the chat box during the presentations as well. So we do have a few minutes left for question and answer and discussion, and as a reminder, we will prioritize those questions from the Opioid Policy Fellows and from NCSL's members of legislators and legislative staff, but we will do our best to get to all of your questions. And Representative Pugh, you're not off the hook quite yet. There are a couple of questions about hub and spoke. In particular, two questions, I'm going to throw them both at you. One is when you're talking about medication-assisted treatment or MAT, and I think you referenced methadone, and the question was if it was just methadone or other forms of medication-assisted treatment like Suboxone or other things.
Thank you. I'm sorry if I wasn't clear. In the hubs, for the most part, it is methadone, but Suboxone can be dispensed there as well. In the spokes, or also known as the physician's office, it would be Suboxone or something else. And I see that Joshua Miller has a question: what % of the population that could benefit are enrolled for both? Well, hub and spoke, what we have, it's hard to figure out, it's hard to identify who is not being served, who hasn't asked, or who has not presented themselves. We say that we maybe are meeting a half to 2/3 of the population of people who could use the services, but not all of them are ready for them, if that answers that part. And CHARM is, the second question was how much of the population in terms of CHARM. In terms of CHARM is a regional, it's out of the University of Vermont Medical Center, which is our largest hospital serving the largest population center of Vermont, probably about a quarter of the population of Vermont, and some in upstate New York come there. And every pregnant woman who comes to that hospital who has opiate disorder or who has been identified or who was not identified before and at the time of birth it became clear are part of that.
Thank you, Representative. There's another question on medication-assisted treatment in the hub-and-spoke model and on any ways that the state of Vermont has encouraged primary care doctors to agree to prescribe MAT.
We worked really hard with the medical center, and a lot of the majority of our physicians are attached to the Medical Center of Vermont and the UVM Medical Center, and they, in the last couple of years, have become much more open and willing to do that. We, with some federal support, we also provided a little bit of incentives to some individuals. But the other thing is the way we have encouraged it is I want to say back a previous governor, Governor Shumlin, identified this as a public health problem, and that has so changed the conversation, and people need to, and physicians in particular in Vermont felt the need to do that, to respond to and be a participant in this. And I want to say there were years of education and connection, and people are increasingly participating. It has been hard, and people are participating.
Great, thank you. And thank you all for your questions. Unfortunately, I don't know that we can, there were a couple others that floated by that we weren't quite able to get to because we are at the top of the hour. But I think that Representative Sexton covered some of them on, other sectors being involved and in some of these efforts too. So thank you both for, or thank all three of you for your presentations today, and I want to thank everyone on the line for your participation. And lastly, but not least, I want to thank the Centers for Disease Control and Prevention for their support of the Opioid Policy Fellows Program. As a reminder, NCSL has a variety of resources across health and other state policies, and we're here to help you address the needs in your state and answer any questions. I've also put up a link on this page, which it links to our legislative tracking on both ACEs and about 6 opioid misuse prevention topics. As a reminder, the archived copy of this webinar, both the recording and the slides to download, will be available in the next week or so on NCSL website. And as you close this screen, an evaluation survey will pop up on your computer screen. And it's very short, so if you will take a few moments to complete that, it really helps us create the most meaningful and beneficial programming in the future. Thank you all again for your participation, and thank you so much to our presenters, Dr. Melissa Merrick, Representative Sexton, and Representative Pugh. Have a wonderful day.
Thank you. That does conclude today's webinar. We thank you for your participation. Have a great day.